Good morning. I'm Ira Katznelson. I currently serve as Interim Provost at Columbia University, as you know, and ordinarily I teach political science and history. Welcome to this faculty forum on renewing the campus with a focus on facilities and public health. This is not a simple time. On the 22nd of January, a first notice went to the campus about the COVID virus. It was a message monitoring events in Wuhan. And by the 15th and 16th of March, we were closing down the chapel, the gym, the library in a very concentrated period of shutdown followed, including undergraduate students leaving their dormitories. We're now in a different kind of position of active planning for the renewal of the campus. This too is a complicated matter. It entails judgments about the restoration of density to the campus in a phased way over time, and in a manner that can be done as safely as possible. Our collective goal is to make the campus not just as safe, but safer than the surrounding city and community. As we've done our work in the past, we've had a rigorous process that has involved the creation of a COVID-19 task force that has met virtually every day, peopled by colleagues in public health and senior administrative leaders of the university. In April, I appointed 4 working groups on public health, on education, on facilities and campus life, and on research that have done an extraordinary amount of work to get us to the point where we're at now, which has included a research ramp up that is underway and a return in a measured form to clinical education at Columbia University Irving Medical Center. Our goal today is to talk about and think about risk. Risk in a double sense. Risk in the sense of the situation we collectively confront, and risk in the sense of how we are acting as a university to mitigate risk, reduce the capacity of the virus to do harm on campus. How do we increase safety and confidence as we aim to return the campus slowly but surely to a more vibrant existence? And we're enormously fortunate today to have a number of colleagues lead us in this discussion. Especially fortunate that Donna, Lynne, Senior Vice President and Chief Operating Officer of our medical center, and former Lieutenant Governor of Colorado, has agreed to steer our collective process of implementation as University COVID Director. And in a moment, Donna will lead us off and will moderate this meeting. Our other panelists include, and I'll do it in alphabetical order of their last names, Melanie Bernitz, Associate Vice President and Medical Director for Columbia Health, and Associate Professor of Medicine at the Center for Family and Community Medicine. Wafaa El-Sadr, University Professor of Epidemiology and Medicine and Director of ICAP at the Mailman School of Public Health. David Greenberg, Executive Vice President for University Facilities and Operations, and Ann Thornton, Vice President and Vice Provost and University Librarian And Anne has been the convener of the working group on facilities and campus life. And I should have mentioned that Wafaa has been the convener of the working group on public health. And before turning to Donna, let me just note that this event is divided in two presentations from our colleagues, then questions and answers. Some questions have been sent in advance, but you can also use the Q&A function in Zoom to pose questions. Questions that we won't get to will be addressed in FAQs on the COVID-19 website. And I urge you all to make regular use of that quite remarkable website at it's covid19.columbia.edu, which is a repository for information and resources. And finally, let me say that this event is being recorded and it will be posted on the web following the event. And finally, there will be another forum aimed primarily at CUIMC, probably on Monday evening of next week. So thank you all for being here, and I keenly look forward to the discussion. Now on to Donna.
As Iris said, I'm Donna Lynne, and I've been at CUIMC since January of 2019, but I'm also a Columbia graduate and have spent the majority of my career here in New York. One important thing for you to understand, in addition to all of the deliberations that Ira and many of us have participated in over the last 4 months, is the fact that what we decide has a larger framework, a larger context, and that is one that is set by Governor Cuomo. And as you know, Governor Cuomo has been very active and has been lauded for his and his administration's great work in moving us to a place where, in fact, the infections are diminished. The death rate, even on Saturday was 0 in New York City. And so we have lots to be proud of, but we also have a lot of uncertainty. And the governor's public health emergency still exists. And we have to abide by many of the conditions that are laid out by the governor. Ira said something very important, which is while many of the students left the campus, but not all, and many faculty and staff otherwise were working remote, there were a substantial number of individuals who continued to either live on campus, to work on campus, because their work was of an essential nature. It's not to say that others wasn't essential, but performing those essential duties on the campus was important. And that ranged from the clinical faculty and staff up at CUIMC to staff across all 3 campuses who are involved in securities and facilities, in providing other supports to students, including healthcare. We've been very active, not only in deliberating, but also in communicating, making sure, whether it was President Bollinger, it was the Provost, or it was others, in trying to make sure that everyone understood how we were doing things, why we were doing them. And I would emphasize, though, that there is still a great deal of uncertainty. Ira used the term risk. There are no perfect answers to how we are going to reopen and bring people back. And there is always that element of risk, but there has been an incredibly deliberative process to make sure that we consider what else is going on in New York City, New York State, and around the country. So despite the fact that we did shut down a number of buildings, emptied out the campus, we had to bring into place a number of the safety measures that I'm sure many of you are familiar with now, whether it is signage, it is implementation of physical distancing requirements, a distribution of personal protective equipment, and other measures that have literally been instituted since early March. We've begun, and I think as many of you are aware, what we call the research ramp up, so that beginning June 22nd, many people began to return to campus. And we asked for 3 conditions as new faculty and staff return to campus: that they complete something called a symptom attestation, that they have a gateway test, and that they also go through training. And that has been done in a very safe and effective manner, and you'll hear about that later. So where we are now, as you saw, is that the President Bollinger announced on July 7th that we are going to reopen. I'll use that word, and I like to use it in quotation marks because we have been open, and that there's still some uncertainty about how and when and many of the other aspects of the reopening. The governor, as I said, maintains the right to determine when we reopen, and he has announced phases whereby different businesses and organizations are eligible to reopen based on the 7 regions in New York State, New York City being one of them. Higher education fell into 2 of the phases. Phase 2, which we're already in, was for the resumption of higher education research. And phase 4 is for the resumption of all education, including higher education. And phase 4 has not been announced in New York City, although it has been announced in several other regions based on their ability to hit certain health metrics that are very clear. As the governor announced those phases and also gave us guidance in May and June, his administration specified mandatory practices that we have to adhere to, and also some recommended practices. The mandatory things fall into the buckets of screening, as I mentioned, testing, contact tracing, hygiene practices, PPE, and communication. I mentioned the working groups, and they have provided us with much guidance and recommendations. We've also looked at our peer institutions who are in urban areas to understand their reopening plan, and ours very much mirrors, with some exceptions, the plans that you've seen, again, particularly in urban areas and in the Mid-Atlantic region. Obviously, you've seen things like California, where those are changing rapidly. And flexibility is going to be a key theme around what we talk about today and as we go forward. The trustees did approve or endorse our plan. We have a draft, and we will be finalizing that. That is one requirement that we have to comply with for the state, is to actually submit a reopening plan. Last, I just want to emphasize, as Ira started out, he talked about safety, and first and foremost, safety is what we are going to put first. Between today and mid-August, and then subsequent to mid-August, we're going to focus on how we handle the many issues that I know many of you will bring today. And following that, we've given schools flexibility in terms of how they reopen, and of course there are going to be many different types of circumstances that we will have to confront. I will close and turn it over to Wafaa, who is going to talk a little bit about the public health context by re-emphasizing our website, which is the place where you should be going for up-to-date information. It's very, very comprehensive. And I look forward to helping sort through the questions that we get today and continuing to work and communicating with all of you. So I'll turn it over to Wafaa.
Good morning, and thank you very much, Ira and Donna, and for the opportunity to speak to you today. And what I'm going to do is walk very briefly through some of the key public health perspectives that we have been keeping in mind throughout the past several months. This is an outline of the presentation. I'll very quickly touch on the transmission of SARS-CoV-2, the virus that causes COVID-19, talk about some key measures for controlling transmission or control of the epidemic. Then I'll touch on monitoring the epidemic in New York City and at Columbia, and then how we are using the data for action. As many of you are aware, the major way of transmission of the virus from on your left-hand side, somebody who is infected, to on your right-hand side, a susceptible person, is through what are called droplets. Droplets are usually greater than 5 microns in diameter, and there's a need for transmission occurs most likely when there's a distance of less than 6 feet between the infected host and the susceptible host. In addition, also, it's thought that the virus can be transmitted by fomites, and this by fomites we mean surfaces, as well as also by aerosol. and aerosol means a very small droplet nuclei, which are less than 5 microns in diameter. So as we think about control of the transmission moving forward, we're really focusing on both prevention of transmission by droplets, aerosols, and fomites. Very quickly, and this is an important number to keep in mind, and a parameter called R0, and this is the average number of infections that are produced by one infected person, average number of infections by one person, and you want that to be less than 1. If it's less than 1, it means that the numbers of new infections is decreasing. And it's estimated that COVID-19, the R0, is somewhere between 1.5 and 4, more likely are a 1.5 to 2. It reflects 3 measures, and this will be important as we talk about New York City data. It reflects the per contact transmission probability, and we can decrease that, for example, by measures such as hand washing. Also reflects the average number of susceptible infectious contacts, and this can be, of course, affected by the increasing distancing, and lastly, by the average duration of infectiousness of the particular virus. And as you can see, there are examples on the right-hand side here of other viral infections, and there are not. And if you look at seasonal flu, it's thought to be about 1.3. So remember that number because I'll get back to it later on in my presentation. So very quickly, as there are various responses that need to be put in place based on where the epidemic is at, from the introduction or emergence to localized transmission to amplification, which was the phase that we were in. And now some of the southern and western states and southwestern states are in now, which means ongoing sustained community transmission. And then the phase of reduced transmission, which is what we're seeing now in New York City, where we're attempting to build on the control mitigation measures and build some suppression measures in order to achieve elimination of the virus. So what are the control and mitigation measures that we have at our fingertips? There are some population interventions, and these include the limitations on mobility, like the stay-at-home orders, restrictions on travel, domestic and international closure of schools, limit congregation of people, and physical and social distancing. These are population level interventions. Then there are individual non-pharmaceutical interventions, and you're well aware of these. These are individual things that one can do by using face covering or mask, hand washing and sanitizing, the cough and sneezing etiquette, disinfection of surfaces, staying home if one is sick, etc., etc. And lastly, there are some biomedical interventions, and we'll touch on them. Melanie will talk about testing, also the vaccines, availability of vaccines, antiviral treatments and prevention, and neutralizing antibodies for both prevention and treatment. So I'm going to focus on a few today, obviously because of the time constraints. First of all, physical distancing. And as you're well aware, the goal is to be at minimum 6 feet apart from other individuals throughout this phase. And what is the evidence to support the effectiveness of physical distancing? These are data from a meta-analysis that was published very recently. And you can see here, just focus on this vertical line, and this is 1. So anything less than 1, the result less than 1 favors the effectiveness of distancing. And I think what you can see here, based on these variety of the studies that were included in this meta-analysis, some of them from the US, others from other countries around the world, is that overall, the meta-analysis shows that physical distancing is associated with less risk of transmission of the virus. This is another way of showing it, and it shows here the distance from the source of infection, and then the risk of infection. As you can see, with increasing distance from the source of infection, there is less risk of infection, which is good news. We also know from other data, including New York City and elsewhere, that physical distancing has worked. If you look here at the city lockdown in this figure on the right, and the effect on decreasing the numbers of cases over time. And you can see at the same time period here, the decrease in average distance that people were traveling, and the increase in percentage of people who are staying home, and so on. So this distancing has been shown to work in in variety of different settings around the world. What about face covering and mask wearing? And that's another issue that comes up all the time. And people ask the question, what's the effectiveness of face covering, mask wearing for both prevention of transmission, meaning from somebody who's infected to somebody who's susceptible, and then what's its effectiveness for prevention of acquisition, meaning getting infected from someone who has the virus. And there's some interesting data. I'll go quickly through them. First of all, does mask wearing prevent transmission from someone who's infected? And this is a very instructive case of, this is from China, of one individual. And this individual took a bus ride over 2 hours and 10 minutes and was not wearing a mask. And he essentially 5 of 39 bus riders acquired SARS-CoV-2 from this one person who's infected. This person decided during the bus stop when he was changing buses to buy a mask, which is a good idea, and then went on a longer ride over time, and he, while wearing a mask, there was 0 transmissions. But this is one case. There are more substantive data that show this, and this is one important study, very recently published as well, that looked at both droplets as well as aerosol, and that's very important. And here you can look on this side here, the amount of virus that was present both in the nasal swabs of these individuals as well as in the throat swabs, and then how, without what happened with looking at the amount of particles that were recovered that were without a mask versus with a mask, and there's a trend here to the effectiveness of the mask. And then you look at the aerosols, and again, without the mask versus with the mask, and you can see that the recovery of these particles was certainly influenced in a positive way, or by decreasing the recovery of droplets or aerosols. So this supports the effective and potential effectiveness of masks for both droplet transmission and aerosol. What about prevention of acquisition? And this is from the same meta-analysis that I mentioned before. Again, keep an eye on this vertical line here. And to the left is favoring mask wearing, to the right not mask wearing. And you can see again in these various studies that were done that looked at both non-healthcare and healthcare settings, that in these contexts, again, the ultimate results show that the results favored that wearing a mask protected individuals from acquiring the infection. Another issue that I'd like to, of course, influence is what happens in the community is herd immunity. You've heard this term. And herd immunity is the prevention of new infections due to immunity within a population. But current studies show very low proportion of populations have antibodies. For example, in New York City, as of May 2nd, I'm sorry, about 20% of individuals in New York City had antibodies. In Sweden, about 7%, and you need about 60% of the population to be protected in order to decrease transmission effectively. Of course, vaccination is one important way to boost immunity, and just to update you very quickly, we anticipate that hopefully there'll be vaccine by the end of this year, the beginning of next year. And the good news, there are several 10 candidates now in clinical evaluation and more than 100 in preclinical evaluation, and many of these are moving rapidly into large phase 3 studies. So let me move on to another element of my presentation today, which is how are we keeping an eye on the pandemic, both locally and globally, which is very important. And we're doing this through public health, COVID-19, Columbia Public Health Dashboard, and I'll show you some of the data we keep an eye on. Of course, very importantly, the New York City COVID-19 epidemiology, and you can see here, we keep an eye on the numbers, daily numbers of cases. You recall, as Donna mentioned, the rapid increases in cases in March and April, and then a slow decrease, and we keep an eye on the numbers of cases, and we're now down to about 30 cases per million. We also keep an eye on the PCR, the test positivity, diagnostic test positivity, and it used to be extremely high at 60% positivity, and now in the city it's down to 1.3%. We also keep an eye on very important data that Donna shares with us, which is the CUIMC data, and I think importantly here I point you to this figure here, which shows that the percent of non-COVID patients at CUIMC, and you can see, of course, comparing May to now, the increase in non-COVID patients in the hospital and the decrease in the numbers of COVID-19 patients in the hospital overall, over time. These are all good news. In addition, we keep an eye on New York City mobility data. We can tell you how many people are swiping at 116, 125th, and 168th Street station, subway station, for example. And we also keep an eye on just mobility overall. And you can see over time the increase in mobility of individuals in New York City, as well as the increase in ridership in subways as well over time. We also keep an eye on New York State metrics. As Donna mentioned, this is very, very critical because we can only do what New York State allows us to do, and we keep an eye on those metrics as well over time to make sure that they're all going in the right direction to enable us to reopen successfully. We also have had the collaboration with Wan Young, an epidemiologist here at the Mailman School of Public Health, and she has been modeling R0 or RT, what I mentioned, the metric that I mentioned to you before, that's really important, that's driving, that tells us about the transmission in the city. And now she estimated that the RT or R0 is at 0.88 in the city overall. So that's good, it's less than 1, and we want it to be much lower than this, but it's heading in the right direction. We started out in the black line here with much higher RT early on, and we're now less than 1. We've developed this kind of table. We monitor the epidemic. We have a lot of metrics here that include, for example, the numbers of cases in the city, the RT in the community, RT on campus, positivity of PCR tests, New York City or amongst our own students, et cetera, et cetera, et cetera. And we look at these and over time. And what we're doing is we're using these for action, using the data for action. So at the top here, you see some of the priority metrics that we are monitoring, some of the key thresholds that we have identified based on those metrics. And then what are the parameters that we can adjust based on those thresholds? And we have a lot of parameters that we can adjust based on what's happening in the city or on campus, all the way from enforcing the face covering, modifying testing frequency that Melanie will talk about, canceling sports events, to gym closures, to restricting students to campus. So as you move from the left to the right here, these are essentially more stringent parameters that we can put in place based on the thresholds that we have identified. I just want to remind you again, before I end, the COVID-19 website has a lot of resources, and if you look at the public health guidance, you can see that we describe in detail some of these parameters and issues that I think would be you would find extremely helpful, and we keep updating this as we move ahead. And I want to end with this image, and I think others will comment on it, but what we're all aiming for is a safe and COVID-ready campus. Thank you very much, and I will now hand it over to Anne to continue her presentations. Thank you.
Hello, everyone. And thank you so much, Wafaa, and to Ira and Donna as well. I'm just going to share my screen now, and here we are. Great. All right, so I wanted to tell you a little bit more about the Campus Ready work that's been going on. And the main objectives for the Facilities and Campus Life Work Group are these that you see here, with a real focus on offering direct support for schools in their own planning efforts for how to reopen safely. That's everything from providing specific guidelines, some templates, working with them on floor plans, and also doing building specific assessments as needed. And we had a real focus on this for the research ramp up, but this work continues as schools have made their plans accessible to us. And we are also taking into account all of the public health guidance as well as the New York State higher education guidance to mitigate risk. And this is being done through a variety of ways, including modifications of a wide variety of spaces, from classrooms to workspaces to libraries, and much more, as well as new protocols for custodial services, as well as for the HVAC mechanical systems within buildings. And you'll be hearing more about those particular outcomes shortly. We also are, in the campus life aspect of our work, are really focused on achieving community adherence to the public health guidance. This is both in the form of policies, the Columbia Community Health Compact, which we'll talk about in a moment, as well as a coordinated program for adherence. So our work involved frequent consultation with the public health group and the other working groups. There are lots of interdependencies among them to address the most challenging issues that we've had with spaces in order to incorporate the physical distance requirements, as well as manage a reduction in on-site population. And we have provided the guidance for schools, including the common areas, thoroughfares, lots of work around restrooms, and different layouts, floor layouts, to support these requirements. These are all available in what's called the document library on the COVID website for Columbia, and I encourage you to take a look there at the kinds of things that are that we've put up there, and that site is being added to all the time. The coordinated efforts with the other groups, and specifically with public health, have also resulted in recommendations to the COVID task force at Columbia on topics such as face coverings, which you'll see in a moment, policies on access to campus for vendors and visitors, as well as how to enforce the health policy, and includes also libraries recovery efforts, which we also recommended to the task force. So I'm pleased to be joining you today from inside Butler Library, where we have staff on site as part of the research ramp up, where for the last several weeks, staff have been working for a safe start of library services. And we now have available not only all the online resources we have, but also a scan and deliver service from our collections, as well as a contactless book pickup service, which is available as of today. We will be expanding that book pickup service before additional services become available online. And what we are working very hard on now are how we can reopen spaces safely with some kinds of restrictions. And so we don't yet have a timeline on that, but we are working on that in coordination with school reopening plans to understand their on-site populations and the anticipated uses of the libraries. The Columbia Community Health Compact is what we all expect from the university, as well as what we need from each other. And it really is to reinforce community health ethos, that every member of our community is responsible to abide by the community health protocols. And this is available right on the COVID website. What I wanted to emphasize that it's not just a statement that we are all supposed to adhere to, but it's really a very comprehensive and coordinated program that is being led by University Life. It includes many, many activities, including lots of student involvement, direct student involvement, and peer-to-peer reinforcement. University Life really welcomes faculty involvement in this. If this is something that is important to you, University Life would love to hear from you, because we think there's a way for faculty to be incredibly helpful in reinforcing this message. And so please do reach out to Suzanne Goldberg directly. I wanted also to share what the university is providing in terms of face coverings. So these are reusable, washable cloth face coverings. There are 2 designs here, and we expect to receive them within the next 2 weeks. And they will be distributed to the school, through the schools, to all members of our community, all students, faculty, and staff who will be on site will be receiving 2 of these, 1 of each design, as I understand. This is to help us all abide by the compact because face coverings are such a key part of that. I'm going to stop sharing that now and turn the presentation over to others. Thank you so much. I think David is going next.
Yes, thank you, Anne, and good morning, everybody. I'm going to start to share the video now. Today, we'll be talking about changes that we've made, enhancements that we've made to our custodial services, and also looking at our heating, ventilation, air conditioning systems as we both get ready for the research ramp-up, which has started, as well as the reopening of campus. We'll look at the campus signage that has already been installed and will be continued to be installed throughout the next month till in preparation of reopening of the campus or repopulation of the campus. Talk a little bit about our building readiness checklist that we do for each of the buildings prior to deeming it fully ready for occupancy, and then mention about transportation. As we looked at our custodial plan to address COVID-19, we took our base building plan and enhanced it with both new tasks, added services, and new techniques. And we based this on guidance from several different entities, both governmental from the CDC, New York State Department of Health, and also other entities such as our own environmental health and safety. And we've both met these standards or frequently, in terms of frequency or addition of service, exceeded these standards. The new custodial initiatives that we have put in place or enhanced include a survey and installation of automatic and touchless fixtures, faucets, flushometers, in also automatic paper towel dispensers. That is being done across the Morningside, Manhattanville campuses, as well as partially at the medical center. The disinfection of high-touch campus public spaces exceeds the standards by being done twice daily. This includes doorknobs, places that people touch, such as entries to buildings, elevator buttons, etc. And also incorporating new techniques that we use for cleaning, such as electrostatic cleaning in classrooms, public spaces, fogging and disinfection in gym, activity rooms, other high-volume rooms. And we're also spreading out more hand sanitizer stations in campus buildings at entrances, at elevators, and other areas of high activity. In addition, we'll be increasing what we call policing of campus buildings, public spaces, as general custodial cleaning of all these areas, increasing the frequency of that, and also increasing frequency of cleaning in classrooms in between classes at a couple times during the day. There will also be increased steam cleaning of restrooms, going from what we had done once monthly to weekly, which also exceeds standards. As we look at our mechanical systems, we also draw from best practices and recommended practices from several different entities, organizations not only within the United States, such as CDC and ASHRAE, but also REVA, which is a European organization for HVAC systems, And we keep in constant contact with peers across both New York City and the country through forums with the NYECC and the APA Facilities Forum. When it comes to our mechanical systems, some of the revised protocols that we have include focused, dedicated inspections of all of our systems to assure the indoor air quality, looking at all of the filters, the fans, making sure that they're all working and in very good shape. We're enhancing our air filtration of existing HVAC equipment to meet or exceed these standards that I was mentioning, such as the filtration of our central air systems, and I'll get to an example of that in a moment. And also looking at enhancing ventilation to lessen the suspended particles in the air. This is specifically bringing in more outside air, maximizing that as much as possible in our building systems and in areas that are naturally ventilated with windows. And we're continuing to look at any other technology that could help prevent propagation of virus, such as UV lighting in our air handling systems. As I mentioned, some of the additional measures is to increase our airflow throughout our buildings, running them possibly 24/7, but certainly on extended hours to continue to move the air through the buildings to remove virus particles. Increase the airing in buildings that don't have central HVAC systems. This could be as simple as keeping more windows open or finding other ways of bringing outside air in, and maintaining negative pressure in all of our toilet rooms to sweep the air out of them. What you see here is a chart that we do for all of our buildings. We're in the process of completing, we've gone through all the research buildings, we're in the process of completing other buildings that looks at a system-by-system assessment of the volume of air that's being pulled through these systems, whether they're outside air, recirculated air, what percentage, and the installed filters that we have, and bringing them up to a higher standard to increase the particle filtration within each building. Moving on to campus signage. For those who have been on campus, you have seen that it is blanketed with new signage, both exterior and interior. And this is all to support the new protocols that we've put in place to decrease the transmission of COVID-19. We're providing guidance for building entrances and exits, use of stairways, elevators. We're posting capacities for the elevators, as well as bathrooms and classrooms. The circulation patterns are being delineated on the floors and with stanchions. And we also are encouraging specific behaviors to improve the public health condition of mask wearing, hand washing, and I have a few examples to show you on that. And there's also many exterior signs across campus, including on College Walk and near the South Fields, encouraging the use of masks. This is just an example of a general 6-foot physical distance signage that you'll see across campus. Here we have a suite of our signage for the public areas, exits, hand wash stations, directional signage that can be on the floor or the walls, and also capacities for this, in this case, classrooms, but we also have them posted on restrooms and elevators. This is an example of the elevator and stair markings. Stairs will show you staying to the right, maintain proper physical distance while you're on the stairs. We'll be looking at stairs that where code allows, stairs for going up and stairs for going down if they're very tight stairwells. And we have markings on the floor. This example here is mud, the mud building, markings on the floor for where people can stand for proper separation. For each building, prior to saying that it's ready for occupancy, we have a building readiness checklist, which is a multi-point checklist that we go through that involves looking at all of the cleaning and HVAC items that I discussed prior to make sure that they're done, that they're in place, that the signage is in place, and that the whole building in the area is ready for occupancy. Based on a suggestion from the Council of Deans, we'll also be posting this by doorways, entries, and elevators so that people coming to the buildings will be able to see that this checklist has been completed for their building. The last area just to touch upon is the work that we've done on the transportation side. Over the last several weeks, months, we've increased service on both the intercampus shuttle as well as the Lamont shuttle. We've added additional capacity, increased the hours, and also added some weekend service. We have outsourced our evening security shuttle to VIA, which gives folks a point-to-point service for faculty, staff, and students. And we're in the process of developing a commuter shuttle for New York City and also surrounding areas to supplement their travel to work. And an example here to the right is that on all of our shuttles, our drivers have been instructed to not let anybody on board unless they're wearing face coverings. We've come out with this signage, which is being implemented across all of the shuttles. There's more detail on all these points that is on the COVID-19 website, and also as an appendix to this presentation that I believe will be posted at a later time. And with that, I will turn it over to Donna.
Great, thanks, David. And I just want to emphasize, although the majority of you on this call are on the Morningside or Manhattanville campuses, also at CUIMC, where we'll have a separate town hall. We have been working in parallel with David and his team. And again, there's been quite a bit of traffic here throughout the public health emergency, so that those markings have been in place, and we'll continue to monitor bathrooms, ventilation, et cetera, along the lines that David identified. I do think there's one really important thing, is that face coverings are going to be required. The face coverings you saw from Anne were an example of what we will be giving out, but face coverings, other than in a private office right now, are required. We're using traditional surgical masks, and those have been distributed to everyone. And I know elevators are a topic of concern for many people, because while you can safely physically distance in lobbies for the most part and other spaces, elevators create special problems. And so we are recommending elevators up, stairs down, or where there's multiple stairwells, we could have a designated stairwell up and stairwell down, but we're very mindful of the fact that elevators pose some problems, and if we have to resort to lobby monitors, we will resort to lobby monitors. We're seeing, as we add more and more faculty and staff back, what problems that poses, but we are very mindful of it. Last thing I'll say before turning over to Melanie is to reinforce the compact, because the issue of enforcement, David used the term policing. It's a generic word that we want to emphasize, because each of us, although I'm not a security person and many of you are not, we all have a responsibility to each other to enforce and reinforce the importance of whether it's physical distancing, mask wearing, and other safety measures. So that was part of what the compact is, and it requires faculty, staff, students to adhere and make promises to each other about that. So I'll turn it over to Melanie Bernitz, who, as you know, is the leader of student health and many other things on the Morningside campus, to share with us some of the work that's being done in testing.
To talk a little bit about testing, as we've explored the testing strategy for our resumption of campus life, we've been guided by some public health principles that will apply to the testing approach for Columbia. And these include an approach that is consistent across campuses, schools, and departments. It's very important that we have consistent practices and recommendations for testing. Also, to ensure that there's no out-of-pocket costs for individuals within the testing program, Columbia will assume the costs of this program. We wish to use one laboratory. This is important to ensure we have comparable and valid results, and ensuring privacy around results. We want individuals within our program to understand their rights around their test results, the confidentiality, and how and when that information is shared. So testing is one prong in a multi-pronged public health approach to resuming campus life here at Columbia, and you've heard many of those approaches already. We add testing to the symptom attestation, the face covering, physical distancing, and all these other changes. And we've been really fortunate to be working with some of the finest public health experts, infectious disease clinicians, epidemiologists, statisticians, and modelers to determine the best path forward for this testing program. And as such, our testing approach is anchored in data and epidemiology. We have to ensure that we're separating out testing those who are symptomatic with those on the surveillance program. So thinking about those with symptoms, they may be identified through the symptom attestation app or through a contact tracer or through seeking care with their clinician or knowing a contact. And there will be guidance for those folks on how to get tested. We've already been providing that guidance through many resources within ColumbiaDoctors in the city. So then we think about the surveillance program and ask, what is the objective of having a surveillance program? Our surveillance program here at Columbia is designed to detect elevated campus prevalence above that which is experienced in New York City. A surveillance program inherently won't detect every case, but other measures are in place that will be minimizing risks of transmission. So the program will assess what is happening in our population, and we'll use that to adjust other measures as needed. So today, with COVID-19 at such low prevalence in New York City, highly frequent testing is not productive or efficient, but obviously that could change. So as we've explored all the options for the testing program, there are 4 key characteristics: effectiveness, feasibility, acceptability, and affordability. So for effectiveness, we need a test that can detect the SARS-CoV-2 virus. The test needs to have high sensitivity and specificity and be able to detect the virus during the infectious period. Feasibility is really important. While we know testing has become more and more available, our program still needs to be scalable. We have to ensure an appropriate test with FDA approval or EUA. We also have to ensure a high turnaround time in a lab that meets the standards set out by New York State. We have to have adequate access to testing supplies and reagents, and some of this obviously is influenced by national trends. And the test has to be acceptable to our population. A nasopharyngeal swab, for those of you who've had them, are very uncomfortable. And there are other methods of collecting specimens now available, such as nasal or a pharyngeal or saliva. We want our affiliates to be willing to come and get tested. And the workflow also has to be quick and non-disruptive. And then finally, affordability. The program must be cost effective. But let me be clear that cost has not been a driver of any decision we are making here. But cost obviously does impact the ability of labs to scale up and the ability to make more tests available and so on. So what is the gateway in the ongoing testing program here? We've spent the last few months analyzing and modeling multiple different approaches for testing strategies for the return to campus. And these are all grounded in the principles I described previously. A large team of experts have been working together to define the best approach for our community, and we will continue to collaborate, evaluate, and adjust so we can be nimble with this program as we move forward. So while I share the strategy that is the current approach, please know that it is constantly being refined and reevaluated as new information and data become available. So the first step is gateway testing for every Columbia affiliate, and this allows us to set our baseline at entry. This is true for every member of the Columbia community who's returned since June 22nd, and will be true for every member of the community who returns in the fall. This is happening currently in partnership with ColumbiaDoctors and Columbia Health, with a site opened specifically for this purpose on the Morningside campus, another site up at the Medical Center, as well as 7 additional sites across the 5 boroughs, Westchester County and the Hudson Valley. And over 1,100 tests have been performed so far, and we're tracking results and working on communicating the results of the surveillance testing. So for faculty, staff, and many students throughout the fall, we'll be taking the approach of ongoing testing using a random sampling approach. And this will allow a point-in-time evaluation of 5% of people on campus at multiple points throughout the semester. and allow us in real time to evaluate the situation. If we see the campus situation trend in one direction or another, we'll adapt in real time. And similarly, if we see changes around feasibility, cost, and acceptability, we can attack the approach. So we're closely monitoring testing strategies, test types, test availability to be able to adjust our testing strategy along with these other elements. We are using a different approach for students in dormitory-like residences. The reasoning behind this is strong and backed up by multiple studies over recent months showing that those living in communal settings are at higher risk for transmission. So this group, once their gateway testing is done, will have more frequent testing. The exact intervals of that frequent testing will be adaptive and flexible dependent on the situation in New York City and on campus. And using the metrics that Wafaa showed, we can track those numbers on a daily basis and adapt the frequency as needed. As I mentioned earlier, any campus affiliate who is symptomatic should get tested immediately. Anyone identified as a close contact or a known case will be asked to quarantine and will also be offered testing at the appropriate time. So how will we support this large-scale testing effort? We are finalizing the vendor who will support all our testing this week. The vendor we select will be able to offer us guaranteed capacity and supplies, an acceptable nasal or oral test, 24-hour turnaround time on results, be CLIA certified in a New York State approved lab with a test that has FDA EUA approval and appropriate validation data, and have adequate pre and post-test analytic capacity. We're mapping out the workflow for the large-scale testing sites, the data management, and we'll share that information with our community about how to utilize these testing sites. This will all be ready prior to the return to campus, and until then, we'll continue with our current program through the partnership with ColumbiaDoctors and New York Presbyterian. So finally, a quick mention on contact tracing. A testing program needs to be partnered with a robust ability to contact trace. If we identify a case, we have to identify those that were exposed. And we here at Columbia are developing and implementing an appropriate, accurate, and comprehensive contact tracing plan for affiliates believed to be exposed to COVID-19 and identified through our testing program. New York City has a test and trace core in place, but Columbia will be supplementing this and will partner with New York City so that we can do rapid contact tracing for our community. As such, we're hiring contact tracing supervisors to cover all our campuses, and they're going to be supported by a team of contact tracers. We'll monitor the changing needs for contact tracing based on the number of infections on campus and our campus practices, such as adherence to physical distancing, and we'll increase contact tracing hours as needed. We'll link directly to the testing program and we'll coordinate with the city, and the data will be confidential. So this way we will be able to appropriately recommend quarantine and isolation for our affiliates who may have had an exposure. I'll pause there because I know we have lots of questions, so thank you for your attention. I hope these highlight some of the strengths of the testing and tracing program we will have in place to keep our campus healthy.
Great. Well, thank you to all the presenters. And we've gotten a number of questions as we've been making the presentation. Hopefully the presentation addressed a number of questions I know people had coming into this. But let's start with a question that I'd like to ask Ira to answer, which is the many faculty were assumed that, or assumed, and we're also, we talked a lot about remote learning, and we certainly moved to that in March to finish out the semester. The announcement that the president made talked about in-person instruction, and certainly there are many areas where that is essential. I can attest for that on the clinical side, but a question about what it will look like in the fall in terms of a mixture of remote learning as well as in-person learning. And hopefully we've given you some assurance of some of the measures that we've taken to make sure that that is done safely. So I'll turn to Ira to talk about the announcement and how we framed instruction.
Thank you so much, Donna, and thanks to everyone for this synoptic overview. As President Bollinger announced in his message in July 9th, we are not going to prescribe an approach for individual faculty members. Faculty can teach, as he wrote, in person, online, or in some contribution of the two, in consultation with their schools. And that last phrase is also quite important. I'll come back to that in a second. Across the campus in Morningside and in Manhattanville, we installed technology that allows so-called HyFlex technology that facilitates face-to-face classes being simultaneously broadcast, and so that folks off campus can participate simultaneously in what essentially is a socially distanced and protected environment for face-to-face teaching. We would like as much teaching as possible to take place in prepared and safe classrooms, but always with an online and hybrid option. There will be classes that will rotate students who are present. There will be other classes that are small in which all who can participate are invited to. And there will be, of course, some classes, think of some studios in architecture or labs, where they only can function with face-to-face instruction. And it's therefore in coordination with the schools that individual faculty will arrange their teaching, and those who are involved in teaching courses that require personal presence will work out those arrangements. And if there are reasons why they cannot do that, they'll have to work out alternative modes of other teaching that they can participate in during the semester. But I know, and last thing I'll say for now is that I know from many emails I've received just how keen our faculty are to return, but to return safely. And we're going to do everything we can to make that return as secure as possible, while also making our courses available to those students who cannot be present with us as the semester proceeds.
Thank you, Ira. The next question that we have relates to a topic that Anne, David, a number of us discussed, which was the requirement to wear a mask, to enforce social distancing, physical distancing. And I acknowledge that there are some spaces where that is problematic. However, the compact, which again, Anne gave you the link to, and it is on our COVID website, reinforces the fact that everyone, faculty, staff, and students, have a responsibility to each other. And the ultimate test of that is that to the extent individuals fail to comply with the requirements that we have around mask wearing and physical distancing, they will face the penalty of having to leave the campus. So it's a complicated question. Security is well aware, but we can't have security guards everywhere to enforce that. But I'll ask David to talk a little bit about other ways in which we're going to be maintaining those important limitations. David?
Thanks, Donna. So we will, of course, have signage across the campus that reminds people about wearing of face coverings and keeping socially distant from each other. Our public safety booths and departments will also all have face coverings that can be handed out as well to remind folks of that. Physical distancing in areas such as the public areas or stairwells, of course the signage points out places to stand and where to move. And even in the case of stairwells, how many steps to stay apart while going up or down. And as Donna mentioned before, where we can, as code allows, we will have upstairs, downstairs to keep people separate in that manner as well.
Could you, David, add though, within a classroom, what a classroom that might have a capacity of 50 would look like now as we move into in-person teaching?
Yeah, so we have gone through, our planning group in conjunction with the registrar has gone through and looked at classrooms and even non-traditional classrooms such as conference rooms to configure for classroom space using a 50 square foot per person or 6 foot separation standard. And we've revised the capacities of the classrooms from what they normally are downwards so that the registrar can use that as they plan out classes. We'll have the capacity also posted on the outside of the class as well.
We've gotten a question about the enforcement of Governor Cuomo's travel restrictions, which now I believe apply for 19 states where individuals are asked to self-quarantine. And of course, this impacts returning students or even returning faculty and staff. Wafaa, could you talk a little bit about that issue? And I will just add to that, that we are well aware that we are a community beyond the walls or the gates that exist. And we are meeting with some of our community leaders to reassure them this Friday of some of our initiatives. But Wafaa, could you talk a little bit about the quarantine protocol and how it will be handled on the university?
Yes, thank you very much, Donna. As you are well aware that this also the list of the specific states is changing day in, day out. And you'll also note that in the symptom attestation that Donna mentioned earlier, that one of the items that need to be checked is whether the individual has been in any of these states in the past 15 days. If they do check that, they will need to quarantine themselves for the duration of 14 days. So we are dependent on people obviously disclosing this information and following through on the requirements of the quarantine. In terms of the students and their return, we have not had detailed conversations as of yet, but I think we will need to also do something similar to that as well in terms of students who are returning from areas that are now having a lot of sustained community transmission. That will be required, as well as the gateway testing that Melanie also indicated as well. Melanie, do you want to add anything?
Sure. Yeah, just to add real briefly that we are in conversations with New York State around quarantine requirements for returning students. And obviously one of the measures that may be in place dependent on where we are when students return is a requirement for either all students to quarantine for 14 days upon their return or for students coming from states that are on the list to quarantine for 14 days. So those conversations with the state are ongoing, and there is potential that students who are in quarantine will take the first 14 days of classes online, even if they are on campus. Thank you.
Thank you. Anne, we have a question for you about our libraries, and a couple, if you don't mind. First of all, what services are available now? And then what's the time frame going forward, and how will curbside pickup work? So now, future, how do you do it?
That's great. So I hope you can see my screen here. So on the right from the library's main page, there is a link to the services that are available now, as well as status updates from the libraries about services that are being turned on or are returning. And so all of that information is available here, including some of the questions that you're asking about when will additional services return. And as we are able to show that we can do them safely and show that to the university through the active work we're doing with space modification and planning for various restrictions to reduce density of population in our libraries, which is a challenge that we're anticipating. As soon as we can show that we are able to do that safely and have safe measures in place, we will be sharing that information much more broadly. So I expect to be able to say more about that in the coming weeks as we head toward the fall semester. But we do have big book pickup services available now. There is detail about this on our website here. When you're in a record, a library item record, here's an example from our Provost. You can see in the item record both the link to scan from a book chapter, or if it's a journal, you can request a scan of an article from our general stacks, or you can request to pick up. And that service is available Monday through Friday from 10 to 3, but you can request the pickup at any time of the day. You'll be notified when it's available. So more to come and more on our website. Thanks.
Thank you, Anne. I'm going to turn to Melanie. We have a question about masks and how people get masks, and what is the filtration of the masks that we've selected that you saw on Anne's screen. So Melanie?
I may not be able to answer all of those. So the mask distribution will be coordinated through University Life with the schools. Probably for the students, we may try and have that with the testing sites. The students, when they're coming in for their gateway testing, could be picking up their mask, potentially for faculty and staff, but we are coordinating that with University Life. I believe we went with a 2-ply mask. Wafaa may have more details on that around the filtration.
Yeah, no, I think there are, even the surgical mask, there's two characteristics of masks that are very important to keep in mind. One is the filtration and one is the fit. So it's really important to have one that's, as according to standards, and every mask producer will have on the mask itself, surgical mask, exactly their filtration efficacy. And then it's also equally important to use a mask that fits well and that's molded to the face and so on, as some of the surgical masks allow for molding to the face, because it's both filtration and fit that matter. For face coverings, 2-ply, as Melanie said, 2 layers, and there's some data out there that having 2 different kinds of materials actually is better. I guess the different characteristics of the fabrics, like cotton and flannel, or cotton and silk, et cetera, but there are characteristics that are important that one should keep in mind when choosing the mask to wear or the face covering to procure. Thank you.
Yeah, I think I'm going to do some show and tell. I hadn't planned on it, but we use the term face covering because in a pinch, anything is better than nothing. So have you seen people with bandanas and the like? At almost all of our security locations, I don't want to speak for every single one, you will find traditional surgical masks, which is put on like this, as Wafaa says, I'm pressing right now a wire that is in the surgical mask that keeps it covered. And I know many of you have seen people like that. We obviously have signage that will reinforce the importance of the fit, not just the utilization of any kind of face covering. We have a question about testing and whether or not family members are included in the testing. I can actually answer that. They are not. And I think one other really important thing to clarify, I saw another question, is the testing that we're doing is for asymptomatic individuals. If you believe you have any of the COVID symptoms, the first thing you do is contact your healthcare provider to disclose that, to talk about testing alternatives as well. Okay. We have a number of questions about transportation, and maybe to go back to David on public transportation, and are we doing anything to address some of the challenges that we know some of our faculty, staff, and students have in terms of getting to the campus? And David, I'll note in particular, there was a question about other boroughs besides just Manhattan.
Yeah, So in addition to the increasing the hours and capacities of our intercampus shuttles and our New Jersey shuttles, we are currently looking at a commuter shuttle that would cover 5 boroughs, as well as picking people up from neighboring counties as well. We haven't finalized it yet, but it's in development, and we hope to be rolling something out in the near future.
Okay, I'm going to turn to Ira for the next question, which we alluded to in the opening remarks, but there are faculty who may not want to come and teach in person because of their health conditions or some other issue, and how will the university approach that?
I think it's fairly straightforward. That is to say, what we've decided not to do is to make it necessary for everyone to go through a formal disability or accommodations process. But it is important that the key leaders, whether department chairs or deans in schools, understand that as faculty make their choices, what they've chosen and how they will adjust their teaching to fulfill their commitments. We are trying very hard to be open and accommodating in very uncertain conditions, but at the same time, all indications are, as we've learned in the return to clinical education at CUIMC, that the vast majority of faculty are feeling secure in returning to direct instruction as appropriate. But we understand fully that there are colleagues with health concerns that make it very difficult for them to do so under current conditions. It's impossible to be more precise than that, except to say that the policies we've adopted and will continue to follow are deeply respectful of faculty and of the ways in which faculty have to make judgments, both about their own circumstances and about our, I speak as a faculty member, collective commitment to instruction at the Columbia community. And I just want to thank everyone really for the thoughtfulness with which I've received communications about just these questions.
Thank you. We have a couple of questions on some health issues that I'll pass to Melanie and to Wafaa. There's 2 questions. One is, there are some universities that are going to be doing antibody testing, and do we have any plans to do that? Second, it relates to temperature screening, which we all see in many locations where we visit outside of Columbia, and is that in fact an effective way to identify individuals who have COVID?
Do you want, I can tackle one and you tackle the other, Melanie? Okay, I'll tackle the antibody and maybe you tackle the temperature, if it's okay with you.
Yes.
I think the antibody, that's an interesting question, and there are a couple of things that that I can tell you about the antibody testing. First of all, number one is there are concerns about the performance, the actual performance of the antibody tests that are available now, and also particularly how to interpret the results in the context where we have a very low prevalence of an infection in the community. So I think that's a great concern, and there's some people who are even saying that having a positive antibody there's a good chance that it's actually not truly positive. So I think there are concerns about the tests themselves. I think the other issue is, what does it mean to have a positive antibody? And that's another question that we do not know if the antibodies are actually effective or protective against against SARS-CoV-2 infection. And also there's concern about the durability. Even if the one has a positive antibody, there are some studies that are showing that these antibodies do wane rather quickly. So I think for those 3 reasons, it is not recommended at this point to do to use antibody testing for decision making.
And I'll just add to that, we are doing significant research around this. There are multiple studies going on. There's a study of healthcare workers. We are studying this in some of the students who've remained on campus so that we can at least add to the information and the knowledge around antibodies and knowing if they will serve a role in the future. Around temperature taking in terms of identifying potential carriers of COVID, it's not that good. We saw this early on with the airport screenings and how little that temperature taking did. So that's why for us it's important. It is part of the attestation, so people should be checking their temperature and reporting if they have a fever. But in terms of screening people out, asymptomatic people generally don't have a fever, so we wouldn't detect those carriers. And even those with symptoms don't always have a fever. So in terms of a mass control measure, probably not good. But as part of the symptom attestation, very important.
Great, thank you. I'm going to turn to David to talk a little bit more about our visitor policy and how that applies to non-Columbia affiliates who are coming onto the campus for whatever purpose, food delivery, fixing an instrument, et cetera. So David, could you talk a little more about the visitor policy?
Sure. So coming onto campus, everybody's expected to wear a face covering, and that's even if you're crossing campus as well, and there's signage to that effect. For people coming to campus, visitors that Donna, you're referencing, we have a similar attestation process to the self-attestation that is on the Columbia app, where vendors, thank you, Anne. There's a vendor clearance to visit campus. This vendor is a broad term that refers not only to your contractors, maintenance contractors, but also professional services, anybody who has business with the university. And they are to maintain records and forward them into central purchasing as well as to facilities and operations, to show that they meet the same requirements that are in our self-attestation on the app, which is that they're symptom-free, they haven't traveled to the states that are on the New York State list of quarantine states, and these vendors, visitors to campus will also have a copy of it with them as well.
Great, thank you. We actually had a real-time conversation this morning about visitors, including individuals coming in for interviews, postdocs coming in, and we are really minimizing the visitor policy and emphasizing the importance of doing everything remote. You can even view a physical space by using FaceTime and turning your phone around. So really we want to make sure that the testing protocols and everything that we're putting in place to keep people safe are adhered to by everyone. Next question, and I'll turn to Melanie, and Melanie and I are very involved along with Wafaa in thinking about testing going forward, but there's been a lot of reports in the media about turnaround time to get test results, and what will Columbia be doing as it expands its testing program for students in the fall?
Thanks, Donna. So the good news is the testing program we have been using is turning around results in 24 hours for the surveillance testing. Certainly you're right that many of the commercial labs, as we see cases increase across the country, are now reporting longer turnaround time for results, 3, 5, 7 days. So that's why one of the critical priorities for our surveillance testing program has been that 24-hour rapid turnaround, so that we can, for asymptomatic people going through the testing, get those results quickly and act in a timely manner. For those who are getting symptomatic testing through some of the commercial labs, while it's frustrating that those results do take a while, a person who is symptomatic will be isolated while waiting for their test results, so they won't be exposing any other members of the community. But obviously the turnaround time has been a key element of our decision-making around surveillance program.
Great. I'm going to turn to Ira to respond to a number of questions that are coming in about international students and how we are handling international students?
This is a fundamental question. As many of you know, the Trump administration issued genuinely ugly guidelines recently, whose only aim is to make life hard for international students. We filed an amicus brief with respect to the Harvard MIT litigation in Massachusetts. The case has begun to be heard. Tomorrow is a critical day, and we're very much hoping that there'll be at minimum a temporary restraining order and perhaps an injunction against the administration, but of course we don't know. So the issues to do with international students are more broad than that. Only slowly have our embassies and consulates been opening abroad for appointments for visas. There's no issue currently, apart from the public health issues, that is getting more time and attention on campus than school by school, ISSO, and elsewhere about how to facilitate the return to instruction by our international students. There have been some detailed pages now sent to deans of instruction about how best to proceed. We're going to do a series of forums, open web forums for international students starting tomorrow. And we've adjusted calendars of schools where necessary and appropriate to take advantage of the 3-term calendar in terms of start dates for various programs, using the division of calendar of Fall A and Fall B, as well as some starts of MA programs being deferred to January. So there's a mix of strategies underway. Our goal is clear. International students are our students. They are part of the community in the same sense that all our students are. And it's our obligation to do everything we can by way of advice, adjustments, information, litigation, to bring them into the fold, notwithstanding barriers put in their way and our way by the policy process.
Thank you. And I want to wrap up. We're at time. It's 12:30. Thank you to all the panelists. Thank you to all of you who participated. We had over 550 participants and 76 questions. We obviously can only touch a few, but 2 things to remember, actually 3 things. First, the COVID-19 website is the source for information. Second, this will be put up on the website, the recording of this session. And third, there is another session that's being scheduled for Monday evening, geared primarily at CUIMC, but not exclusively. So if you have other questions that you want to post, we can respond to them. And finally, the questions that we couldn't get to will also be incorporated into our FAQs from the website. So thank you all for participating, and more to come. Ira, do you want to?
Yeah, I just want to add my thanks to you, Donna, to Wafaa, to Melanie, to Anne, to David. It's a privilege to work with colleagues like these and many others who are using their applied intelligence to bring us back to density in a safe and measured way. And the only last thing I would add is that the planning underway has included very detailed work in each of our schools, appropriate to the local conditions in each school. What we are trying to do at the university level is provide a framework and resources so that each of the units of the university can proceed with confidence as we move toward a somewhat higher density campus in the fall. I wish you all safety and stay well, and see you soon, I trust. Take care. Thank you.